Thanks so much, everyone, for joining. I'm so excited for this session today that's co-hosted by two of our amazing advisors, Dr. Jack Turban, who's an incoming professor of child and adolescent psychiatry at UCSF, and Atlas Alvarez, who is a bilingual youth program coordinator at Trans Family Youth Services. With that, I'm going to keep this intro brief and pass it over to the both of them to share an introduction and kick us off with their presentation. Atlas, I'll kick it over to you first.
Alrighty, thank you. So my name is Atlas. My pronouns are they, them, and he, him. I am non-binary and transmasculine. I'll be turning 26 next month. And I am from Imperial Valley, and it's in the desert of California, right next to the border. So I'm a border town kid. My background, I studied psychology at Cal State San Marcos, and I graduated in May 2021. I'll be starting an MSW 2-year program at Cal State Long Beach next week. So I'm pretty excited about that, looking forward to it. I spent all day on campus on Tuesday, so it's pretty cool to see and just interact with the cohort already. So I work for Trans Family Support Services. I've been with them for about 9 months already, and it's just been a wonderful time just supporting our youth in any way that we can and supporting their family members as well. So I'm pretty grateful to have found the organization and do one of the things that I love doing most.
Congratulations, I'm excited for you to start. And I'm Jack Turban. I'm a child psychiatrist and starting a new job at UCSF. Well, in 2 weeks, I'll have to start working again. And I'll be in their gender clinic part-time, working in the eating disorders clinic and doing research also. But for the sake of time, I want to make sure there's plenty of time to have a discussion session. So I might jump right into the presentation. And today we're going to talk about supporting the mental health of transgender and gender diverse youth. Okay, if we jump to the next slide. We're going to walk through the various stages of development, starting with pre-pubertal transgender youth and how treatment of them has evolved over the past few decades. Then we'll talk about the rationale and current evidence base for pubertal suppression during early adolescence. And then we'll talk about the rationale and current evidence base for gender-affirming hormone treatment with things like estrogen and testosterone for transgender adolescents a little bit later in adolescence. And before we jump into that, just some quick terminology and background that we'll go through. So for terms to know for this talk, I don't have my cursor, but I think you can see on there. The first is sex assigned at birth. This is generally what's put on someone's birth certificate at birth, usually by a physician, and the vast majority of the time it's based on the appearance of external genitalia. This may or may not align with one's gender identity, which is one's psychological sense of their gender, whether that's male, female, non-binary, among other gender identities. For people whose sex assigned at birth aligns with their gender identity, they may identify as cisgender. For people whose gender identity is in some way incongruent with their sex assigned at birth, they might identify with the term transgender. Third term is attraction, and this refers to the types of people towards whom we're romantically or sexually attracted, and we use gender identity as the reference point for this. So if I were a transgender woman and I was romantically interested in other women, I would likely identify as lesbian, but of course it's best to always ask people what terms they relate to themselves. And the last term is gender expression, and this refers to the ways in which we present to the world in a gendered way. And of course, this varies substantially by culture and even by time within a given culture. But for example, if I were wearing a suit, you might think of that as a masculine gender expression. If I were wearing a dress, you might think of that as feminine gender expression, etc. For the next slide, I'm going to kick it over to Atlas for a quick audience participation session.
Thank you, Jack. That was great. All right, so we're just looking at the gender bear, and now we're looking at the genderbread person. Some of you may recognize these symbols. They are used to represent sex and/or gender in biology and medicine. On the left, we have the symbol for male or masculine, and on the right, we have the symbol for female or feminine. So we're gonna do a little quiz for y'all if you would like to participate. I don't know, raise your hands or in the chat or with the reaction button. So is there anyone who could describe this cookie, and how would you be able to put this all together in terms of their gender identity and their sexuality, so their romantic or sexual attraction and their sex? Anyone have any ideas, or just try it out? I wish I could do the chirp.
We
So
have one
Emily,
come in from the chat.
yeah. So Emily says assigned sex at birth is male, gender identity is woman, and attraction is to men. So that seems pretty correct to me. I would say this is a straight cisgender genderbread person. All right. And we have another one. So same thing. If anyone would like to tell me how would they describe this cookie and what their gender identity and sexuality and their sex assigned at birth would be. Oh, I got it mixed up. You're right, Jack. Sorry. So the last genderbread person was a trans female who is attracted to males. Yeah. So in their gender identity, they were female. Their sex assigned at birth was male, and they were attracted to males. So they are a trans woman who is straight. And here we have Mark says male at birth, gender is male, and attraction is female. So that is right. This is the straight cisgender person, or cisgender male. And then lastly, could anyone tell me what this person identifies as, their gender identity, their sexuality, and their sex assigned at birth? You can put it in the chat. Any guesses? So Mark says pansexual and birth. Their sex assigned at birth is female. Questioning. Emily says multiple gender attraction. So yeah, I would say that this person is definitely under the non-binary umbrella. Maybe they identify as genderqueer or gender fluid, maybe questioning, and their sex, they were assigned female at birth, and their attraction seems to be pansexual. So this, in general, this genderbread person would be a non-binary person attracted to people, regardless of their gender identity or expression. Thank you.
Bit more background. So one of the reasons that we're so focused on supporting trans youth in particular is that there are very high rates of mental health difficulties. They're primarily internalizing conditions, which is an umbrella term for things like anxiety and depression. So rates of mood disorders, depending on the study, especially depending on the age of kids in the study, is anywhere from 12 to 64% of kids. Anxiety disorders, anywhere from 16 to 55% of kids. And unfortunately, it seems that these drive high rates of suicidality, with rates of past suicide attempts as high as 30%. The greatest predictors of a lot of these mental health challenges are stigma or rejection based on one's gender identity. And you can see that, unfortunately, is very common. So rates of bullying victimization are as high as 80% in some studies. I think when we looked at the recent CDC data, it was somewhere around 40% who endorsed some recent history of bullying. Next slide, please. So on this graph, on the x-axis is the mean age of participants in a given study. And on the y-axis is the percentage of participants who endorsed a history of suicide attempts. The gray line is the US average. In the black line, it says gender incongruent, but you can think of that as transgender and gender diverse people. And you can see that there's really a dramatic suicidality disparity across the entire life course, but it becomes particularly dramatic in adolescence and early adulthood, right? Kind of the age group that we've been focusing on trying to support. The predominant model for understanding these mental health disparities is something called the minority stress model. It was first described for sexual minority people, so lesbian, gay, bisexual people, by Elon Meyer at UCLA. And then it was later adapted into the gender minority stress model for trans and gender diverse people. And it's a model for describing how societal factors can negatively impact mental health. So first, it describes a set of distal stress factors in the first column. And so these are, I think of them as external factors. So things from the outside world that impact your mental health. If you're discriminated against based on your gender identity, if you're rejected, if you're victimized, if you're not affirmed in your gender identity, so if people are constantly telling you that your gender identity is invalid or that it's not authentic, all of those things understandably can make people feel more anxious and potentially depressed. But what's really novel about this framework, and perhaps slightly less intuitive, were these proximal stress factors in the next column. I think of them as internal stress factors. So over time, as you get all of these negative external messages, some of those start to move into your own psyche. So you might have things like internalized transphobia. The way I see this with a lot of kids is, they may know on a conscious level that the things they hear in the media are not true, right? They're hearing that they're a threat to people in bathrooms, that they're dangerous to people on sports teams, that their identities represent mental illness. Often the kids I work with know on a conscious level those things are not true, but it still kind of eats away at them. Maybe I am mentally ill, maybe I am dangerous, and that understandably creates a lot of anxiety and depression, and particularly problems of self-esteem. Another proximal factor is negative expectations in the future. I think of this as very similar to trauma spectrum disorders, right? So if you were in a car crash, you're going to expect, if you get in a car again, that you're going to be in another car crash, even if that's very unlikely, right? You're going to overestimate the level of risk. Similarly, if you've experienced discrimination, harassment, etc., for your gender diversity throughout your young life, and then let's say you move somewhere new that's much safer, like the Castro in San Francisco, where I've been spending more time, you may still feel that anxiety and threat and expectation of future harassment, and that understandably drives a lot of anxiety. Then the last one that's described is concealment, so hiding your gender identity, feeling like you can't share it with people, and the shame that's associated with that. And of course, all of these things can lead to that last column of mental and physical health problems. The good news is that there are some resilience factors that have been identified that can buffer the negative effects of those factors. So things like community connectedness, connecting with other trans and gender diverse people, being part of a queer community, to see other people who are thriving and are like you, so you don't feel as alone and stigmatized, and also building pride in your community. So, with young people, I'll often point out that transgender people have made huge contributions to pretty much every aspect of society, right? In medicine, in the law, in the arts, in business, and sciences. And so building that pride is really essential for combating some of these other negative effects. Okay, if we go to the next slide. This is a paper we published in 2017 in the Journal of the American Academy of Child and Adolescent Psychiatry. And we asked transgender youth the top 10 things they wanted their doctors to know. So I'm telling you what they wanted you to know. I'm happy to email people the paper if they'd like it, but just a few ones I thought were important. We already talked about this, but that gender and sexuality are totally different things. So they really didn't want people to assume their sexuality based on their gender or vice versa. That non-binary people exist and that their identities are valid. That names, pronouns, and gender markers are important on a basic level because it implies a level of respect and that you're validating their experience and identity. But they also pointed out that when you use the wrong name or pronouns, it can often bring back really difficult past memories, right? A bully who wouldn't use the right name, their parents who trying to kick them out of the house and wouldn't use their pronouns, right? So as much as part of it can be about the present moment, part of it could be conjuring up past difficult experiences. So it's part of why it's so important and why if you use the wrong name or pronouns, it's ideal to apologize and just remind the person that you support them and you're validating them and you're there to be on their team. And then one last quote that I liked. If I'm depressed or anxious, it's likely not because I have issues with my gender identity, but because everyone else does, which I think is a really nice way to sum up the minority stress framework we were just talking about. So let's start going through the various stages of development. So first, we'll talk about prepubertal children. So the first question here in the literature has been about early social transition. So this question is really about for prepubertal children, when they tell you they want to use a new name, pronouns, dress, etc. Do you facilitate that? Next slide, please. So we don't have a ton of data on this, but this is the data we do have. So on this graph, as you go from left to right, towards the right, that's more anxiety and depression. Green is the normal range. Orange is the preclinical range. Red is the clinical range. And I've put 3 cohorts of kids on here. First cohort on the far left is a community sample of transgender youth in the United States whose families let them socially transition. And you can see their mean anxiety depression scores were right in the normal range. Over on the right, there are 2 groups of kids, one group from Toronto, one group from Amsterdam, 2 clinics where they told parents not to facilitate a social transition for prepubertal youth. And you can see their mean rates of anxiety and depression were there in the preclinical range. Imperfect comparison for many reasons, right? These are kids in different countries. Data were collected in different years, so it could be that other factors were impacting this. But I would say what this suggests is that, you know, at least in the short term when this data was collected, the kids who are allowed to socially transition do quite well. We can talk about that more in the discussion if you'd like. The other big question for prepubertal youth was, you know, whether or not it was advisable to pursue psychotherapeutic efforts to push kids to be cisgender, which at this point, every major medical organization has labeled that dangerous and unethical. They've labeled it conversion therapy. But I think it's important to know the data of where that came from. So this is a study we published where we looked at over 27,000 transgender adults. Next slide, please. So what we did was we looked at people who had ever spoken to a professional about their gender identity. We broke them into 2 groups. So people whose therapist tried to force them to be cisgender and people whose therapist did not. So we'll call that a conversion effort group compared to a therapy without conversion efforts group. Those in the conversion efforts group had greater odds of a whole range of bad mental health outcomes, even after we adjusted for a ton of potential confounders. And you can see them all here, a whole range of higher odds of suicidality and past month severe psychological distress. This slide, these are people who were ever exposed to conversion therapy, if you will, in their lifetime. And really around the time this was published, no one was advocating for that after adolescence, but there were people who were still advocating for it for these very young prepubertal children. So if we go to the next slide. So to look at that question, we looked at people who were exposed to conversion therapy during that early childhood phase, so before age 10. And we found that conversion efforts during that period were actually associated with a more dramatic increased odds of suicidality, including a fourfold increased odds of a lifetime suicide attempt. Next slide, please. So unfortunately, these types of conversion efforts are still legal in most US states. On this map, the states in dark green are states that have banned conversion therapy. Pennsylvania actually just added something this week. But all the other states in yellow are states where it's still legal and can be practiced. Next slide, please. This is a paper we published in the American Journal of Public Health in 2019, where we asked transgender people, have you ever been exposed to these types of conversion efforts or conversion therapies, if you will? And we found that exposure was pretty common. So 13.5% of transgender people in the US reported exposure to some type of conversion effort. And you can see there was some geographic distribution and where those practices were more common. Next slide, please. In terms of the policy arena, conversion therapy bans have been challenged in the courts. So in the 9th and the 3rd Circuit, there were cases that upheld that these bans are constitutional. However, more recently, there were 2 conversion therapy bans in Florida, and they were challenged in the courts. In the 11th Circuit ruled that those bans were unconstitutional and a violation of professional free speech. Oh, sorry, I think somebody's unmuted. And so now that there's the circuit split, there's a potential that this could go to the Supreme Court in future years. So it's important to, and if that happened, of course, we could lose all the conversion therapy bans around the country. So it'll be important to kind of track the policy arena. And I think it's also important that people working in this space share the data and what we know about the dangers of conversion therapy to hopefully make sure that public policy moves in an evidence-based direction. So next we'll talk about early adolescence and puberty blockers. So puberty blockers have been around since around the 1970s in pediatrics and were first used for precocious puberty, a condition in which young people enter puberty at very young ages, sometimes as early as 3 or 4. And then later, the Center for Expertise in Gender Dysphoria in the Netherlands started using them for trans youth. Next slide, please. This is just to show that Amsterdam is very beautiful. But this was their big case report that they published. So in 1998, they wrote about a young person who was transmasculine, who had severe suicidality as a young person, wrote a note to their parents saying that they didn't want to live anymore if they had to continue living as their sex assigned at birth. Eventually got a puberty blocker later in life, started taking testosterone, and then had gender-affirming surgery as an adult and had a very good mental health outcome. Next slide, please. The most common way these medications are given are as subcutaneous implants. They're marketed to last about a year, but some studies have suggested they last around 2 years. And the thing that's interesting about these medications is that they'll put puberty on hold to prevent the irreversible changes that come from puberty, but the medications themselves are reversible. So if an adolescent at some point decides they actually want to go through their endogenous puberty, they can stop the medication and that endogenous puberty will proceed. So in that case, they're considered reversible. So since that first case report, clinics around the world have started taking this approach for trans youth and documenting their findings. These are all the studies that we've had so far. You can see they're mostly longitudinal cohort studies. So these are studies that looked at people before and after pubertal suppression. And generally those studies have found improvements in depression, anxiety, etc. There have also been 2 studies that compared people who accessed pubertal suppression to people who wanted pubertal suppression but did not access it. And in both of those studies, those who accessed it had better mental health outcomes, including lower odds of suicidality, anxiety, and depression. Next slide, please. So now we'll talk about gender-affirming hormones in late adolescence. So the main medications that you'll hear people talk about are estrogen and testosterone. The old Endocrine Society guidelines pointed out that most of the research in this area looked at people who started gender-affirming hormones at 16 or older. The latest Endocrine Society guidelines from 2017, again, did say that most of the data is from people who are 16 or older, but recognize that there could be compelling reasons to start these medications earlier in some cases, as early as age 13 and a half. We can talk about those reasons in the discussion if you'd like. I won't go through all of the physical effects of these medications, but there are some physical changes that are not reversible. So they're different than puberty blockers in that way, that make your decision. And if you'd like to see these tables, they're in the Endocrine Society guidelines. And so they talk about all the physical changes that happen when they start and when they reach a maximum. Next slide, please. Again, this approach has been taken around the world, and several clinics have published their results. Mostly longitudinal cohort studies, again, looking before and after gender-affirming hormones. They've generally found improvements in anxiety, depression, and quality of life. And again, 2 cross-sectional studies comparing people who accessed hormones to people who wanted them but did not access them. And in both of those studies, those who accessed them had better mental health outcomes. Sorry for talking so fast, but I want to make sure we have plenty of time for the discussion and really just kind of give us a jumping off point for